Thank you so much for that introduction, and thank you so much for having me today. I'm very happy to share with you about the surgical approaches for intracerebral hemorrhage. Okay, great. So you can see my slides because I have my laptop up here. The first thing I'll mention is I am recovering a little bit from a cold I had last week, so if I cough a little, I do apologize. I'll try to keep it away from the microphone. But I don't have any relevant disclosures to share with you, no financial relationships, any discussion of any industry or products or techniques. They are really just either from my own experience or from just stuff that I've read about, but not any personal financial relationship to those companies. And as was mentioned, I am a cranial neurosurgeon. Vascular and endovascular are my specific subspecialties, but I do skull base and tumor as well. And this is my background. So I'm from Georgia originally. I went to University of Georgia for college. Then I found myself in Miami, Florida for medical school. And then I did all of my neurosurgical training, including my fellowships at the University of Illinois at Chicago. Yeah. Oh, hi. All right, so the outline for today's conversation. First off, I'll talk a little bit about the problem of ICH. This has been the topic of today, so some of this might be a little bit of repetitive from the lectures you've heard already, but I'll talk about it more in the context of surgery. I'll talk about the trials that have really brought us to the current treatment paradigm. I think that's really important because a lot of things have changed over the past 10 years, which I'll get to. Then I'm going to go through some of the surgical techniques, which I think this will be kind of fun to show you some of the things that we do, because there are different types of ways surgically to approach ICH, and I'll show you some videos if they work. And then I'll talk about the program that we have at University of Wisconsin as well. So first off, the problem of ICH. So it's 15 to 20% of all strokes. You've heard this already. So it's a lot. But it's 40 to 50% mortality at 30 days. So it is a very deadly condition. And beyond that, it causes a lot of disability. 25% of these patients are independent at 6 months. So this is significant. And then really up until now, the treatment options are limited. But that has changed over time. And ICH causes severe disability worldwide, not just the United States. But this is an article that looked at the global burden of stroke. And I wanted to highlight this specifically, that in terms of the prevalence, ischemic stroke takes the cake, right? So ischemic stroke is the vast majority of all strokes, whereas we see subarachnoid hemorrhage and ICH are the minority here. However, in terms of disability, that is not true. In terms of disability, ICH actually takes out the majority, or at least half, of these patients, which is an important number to think about. And then over the course of the 30 years that were included in this particular review, the absolute number of strokes increased by 70%. The prevalent number of strokes increased. The deaths from stroke increased. The disabilities increased as well. And so this is a problem that is here, and it is something that obviously we're here to discuss. So really, the problem as a neurosurgeon of ICH is this question: should we operate? This has been studied and across the past few decades in a myriad of ways, but this is really the crux of what I'm hoping to tackle today. But then if we should operate, how? Does that matter? And when? And so I'll make the case that this does actually matter. So I'm sure this has come up a few times already, but there are these guidelines. We have the little copies of the guidelines on your table from 2022. But from 2015 to 2022, a lot from the surgical side has changed in these guidelines. So in 2015, here's what you see. This is it. These are the recommendations. Not much. So specifically, the only positive recommendation, the only strong recommendation was this, that patients with cerebellar hemorrhage should undergo surgery. But then the rest was washy at best, that most patients with supratentorial ICH, the usefulness of surgery is not really established. The policy of early hematoma evacuation is not clearly beneficial. So this is where the guidelines were 10 years ago, as opposed to now, the more recent guidelines that have come out. Now, I won't go through all of this in a lot of detail, since especially we all have copies of it at our tables, but it's just to show how much data has come out since then and how this has really shaped and changed how we think about intervention. But so MIS is now included, so minimally invasive surgical evacuation of ICH, and it's actually showing that it may improve mortality, it may improve functional outcomes. Same thing for IVH. Now we have more recommendations here that there's mortality reduction with EVD placement, that there's some thought to benefit of actually evacuating the IVH, for instance, with neuroendoscopy, EVD and thrombolytic therapy, that could at least minimize how much shunt dependency we have on these patients. For supratentorial ICH that is more severe, here's our recommendations that it could improve mortality. And then, of course, we have the posterior fossa hemorrhage, so infratentorial. This has not changed. This was the one from 2015 where we have a strong recommendation that, yes, we should intervene on those that have cerebellar hemorrhages. And then, ultimately, this is the last recommendation, that there is some mortality benefit, or the potentially mortality benefit, in patients with ICH that is life-threatening. So the trials that led us to today, I'll go through a timeline, if you will. Not all the trials, because there's a lot of them, but I'll highlight some of the most important ones, I think, that have really shaped our current thinking about this. And it's nice to think about it into these three subgroups of time. There's pre-2015 recommendations, what led us to that point, 2015 to 2022 that really shaped the newer recommendations, and then what's happened since then? There's been trials that have come out since then, and then a lot of different techniques that have come out since then. So first, pre-2015, we had our STITCH trials that were very important. So STITCH 1 and STITCH 2, 2005, 2013 were when these were published. And what these were regular craniotomies, not the MIS craniotomies we'll get to, or MIS surgeries that I'll get to a little bit later. But surgery less than 24 hours versus conservative medical management was what STITCH 1 was about. They had about 1,000 patients, but it ended up not showing much. There was not a difference in the functional outcome between these patients, 26 versus 24% at 6 months. And you see that graph there that shows that there's really not a difference between the two. So it was a negative trial. The next one, STITCH 2, there's some separation of the outcomes there, but really it's not statistically significant in these patients. And so neither one of these really supported the use of craniotomy for patients with ICH. But what we do have here is this minimally invasive surgery for spontaneous ICH. This is a meta-analysis that came out, and it showed that there actually might be a benefit here. So maybe not with the regular craniotomy, even if it was early, but here we have MIS approaches, and if you note, it's probably really tiny font, but if you note in the table, there have been studies as early as 1989 for endoscopy in the management of ICH. So they've been coming out with studies for a long time, but in aggregate is where we start to see that there's possibly a benefit here. So this is what really started to drive more of the research from 2015 to 2022. So at this point, we get to this next meta-analysis, which is done in 2018. More studies are coming out at this time, still MIS, and still the same findings here, that there's some benefit in aggregate. When you're looking at all of these different studies and combining all of the patients from the different studies, we're seeing some benefit to MIS approaches for ICH. And then there's this study. So there's MISTY 3. So I'll get to a little bit of what that technique entailed, but it's essentially stereotactic thrombolytic therapy into the cavity of ICH. And so this was published in 2019. And it's another negative study, really, in terms of the main findings, that in terms of survival benefit, there really wasn't much of a survival benefit or functional benefit here. So you don't really see a difference when you're looking at the survival curves, when you're looking at the MRS distributions. But what this study really did, and to shape our thinking about ICH and surgery for ICH, is that third graph. This is an important one. This is where they did a subgroup analysis of patients that had less than 15 cc's of blood left. That's the threshold. So after the evacuation of the blood clot, if those had less than 15 cc's left of blood on their follow-up scans, they had a higher probability of having a functional outcome that was good. And so this is what started to shape our thinking, is that how can we do our approaches so that they are going to maximize how much blood we can evacuate safely, because that seems to be the real threshold here. And so then this leads us to post-2022, more recently. Now, this is the study ENRICH. So some of you have probably heard of this, maybe all of you have heard of this so far, but this was published just very recently, last year. It had 300 patients in there, and what they looked at was minimally invasive surgery, specifically a MIPS approach, which I'll get into the details of what that means later on, but in less than 24 hours compared to conservative management. And they found a significant benefit for death, right? So 9% versus 18% suffered death at 30 days. And then also there's a better MRS that they found also. So this brings us to the surgical technique. So overall, that's how we got to where we are today. So that should be answering the question of should we operate, and I think the evidence is saying yes, we should be operating. But now we're talking about how. Like, if we should operate, how should we approach it? And it seems that the actual way that we should approach this is a minimally invasive approach. And there are several techniques that are published out there. So I'm hoping to share some of these techniques with you and see if see how you feel about them. The first picture I have here shows the different types of catheters, different types of ports that are used, and give you a sense of the size of them. And so top to bottom here are the different needles versus catheters versus ports. And so you go from 3 millimeters in size up to about 1.5 centimeters. So very small access. And this is where we get this minimally invasive term from, because it is a very small way of approaching the hemorrhage. And so craniopuncture, that's a technique that was used more in China, but then we have the MISTI sheath that was used to place a catheter and infuse thrombolytic therapy. The next one is the Artemis device. This is through a 3-port endoscope, like the Storrs Lotta is an example of that. And then a clear sheath is another example that you can use endoscopic or endoscopy for. Aurora surgiscope is a newer one that's available as well. And then brain path endoport. So this is for port-assisted evacuation of hematoma. But just to give you the sense of the size of that, that's tiny. And then there's 2 general ways to group the types of techniques that have been studied. There's the MISTI side, which is more these thrombolytic techniques, where you have craniopuncture, you have stereotactic aspiration with thrombolysis. So those studies required, as I mentioned, placing a very small either catheter or even needle into the place where the hematoma is, and then infusing over a certain period of time thrombolytic TPA, and then over time helping to evacuate slowly that hematoma and it decreased the amount of mass effect. The next category are these non-thrombolytic therapies. So these include the endoport-mediated evacuation. So I list ENRICH trial as an example of that. The specific ones that are listed here include this brain path, which I showed on the previous slide. Endoscopic assisted evacuation. There's a lot of different adjuncts that are out there, including the Artemis system, which is from Penumbra. SCUBA study was published on that. INVEST study, MIND study. There are a lot of different trials that have come out looking at that specifically. And then a surgiscope, which is another way to visualize the hematoma as well. And these trials listed here, the MIRROR trial and EVACUATE trial, I don't believe have been published yet. Okay, so this is what that technique looks like. So this is the MISTI study. So as I mentioned, this is how, like if this is the brain, this is the hematoma here. Oh, I guess you can't see my mouse. Hold on, let me see. All right, so this is gonna be brain, then hematoma, and then this is the stereotactically placed catheter. And this is placed essentially after stability of the hemorrhage has been seen on a 6-hour scan. Then they take the patient to surgery, they place this catheter, and then 6 hours after that to make sure that the hematoma is stable, then they'll start to infuse the TPA. And then they do a certain amount, usually every 6 to 8 hours, and allow that hematoma to slowly evacuate out and get collected out because the TPA is essentially busting up that clot. The next approach I'll show is a scuba. So this stands for stereotactic intracerebral underwater blood aspiration. It's quite clever. But the way that this is done, this is published from, I believe, New York at Mount Sinai. But this shows a catheter getting placed into the hematoma cavity. That's phase 1, and then you essentially allow this hematoma to start to evacuate out. And essentially it evacuates itself for the most part. And as that cavity starts to seal up, once most of that blood has come out, then you actually inject some saline into it. You fill that cavity back up so you can really wash it out even better and inspect to see if there are any bleeders that are active. So then you can coagulate them and get control over that. And then that shows the catheter coming out, and you end up looking like it's like a zipper. You just see this line that's across the CAT scan where you were. So that summarizes the steps that I just went through. And if this video will play, it will show you what this looks like. All right, so I have no relationship to Nico, and this is really just one way that this can be done. There are a lot of different companies that can do this, but the technique is still the same, where you use an endoscope and you use another device that helps to evacuate the hematoma. This is an example of a patient with a hemorrhage, left-sided, and what they'll end up doing is stereotactically placing an endoscope as well as an aspiration device to help evacuate that. And this is not my video, this is on YouTube. So this is the size of the burr hole, so this is how they get access. And then this is them guiding the endoscope into there, and that's the hematoma. Like I said, it kind of evacuates itself a little bit. Once you actually push the port or the sheath into the hematoma cavity, a lot of it herniates just through the sheath and evacuates out. You apply some gentle aspiration, it comes out, and then once you actually see the entire cavity, you can buzz and cauterize any of the feeders. The next technique is the one that's been more popularized by the ENRICH trial. So this is the MIPS technique, and this is minimally invasive parafascicular surgery. So I'll get into what that means, but what this picture is trying to show, or the schematic, is this is the port, so it's a port-assisted surgery, and you place this port more or less along the long axis of the hematoma, but it's more than just that. You're actually trying to be functional about it. You're actually trying to go along the fibers so that you're not crossing the fibers and causing damage. You're actually going along the fasciculus. So it's parafasciculus, but it's also transsulcal, so you don't damage the cortex. So it's all about keeping in mind what's connected to what inside of the brain so that you minimize the damage to those structures. So you bring your port in, and then that gives you access through the port with either an endoscope, you can use an exoscope, which is essentially a camera outside of the device. You can use a microscope as well, but this is what gets you access to the hematoma. And as I mentioned, this is the key, this transsulcal parafascicular access. That's the name of the game with the MIPS approach, and it's just all has to do with avoiding critical structures and really following basic neuroanatomy. So this is another picture that'll show you what these ports look like. So this is just one of the examples. I think this is a brain path. So this is the part of the port. This is actually how you get access. It's the stylet. And then you leave this behind. This is actually the clear tube is what you'll end up seeing things through. So this is really just getting you access. So this is a picture of that. You're going down the sulcus of the cortical surface of the brain. So here's the gyrus, and then sulcus here. And so you follow the sulcus down, but you want to try and follow and be parallel with these different tracks, these white matter tracks, again, to minimize any damage. And so then you get all the way down to where that hematoma is. And so what you see in the pictures on the right-hand side, this is an actual example of what this would look like. Again, just a burr hole, just a small hole to get the port in. You open up the dura here. You start to see the cortical surface. This is, I believe what they're showing in this particular picture is just actually opening up that sulcus. So this is with that sulcus open. And then they start to insert the port. And that's what this is going to look like. That's your visualization. So you'd actually see down the port. And the exoscope, as I mentioned, would be like a camera above the scene. The microscope is the big operative microscope that you would bring in that you get a little closer view, or you could just use an endoscope if you wanted to. And actually, the visualization is so good, theoretically, you could just use your loops to look through it as well. The idea is that it just maintains that corridor for you to see through. And this is just an anatomical picture just to, again, emphasize the key to this approach. And that is that you're being very mindful of the different fasciculi, the different white matter tracts. So you are wanting to follow and be parallel with them to minimize damage, minimize disruption to them. So I do have this video. Let's see if I can get it to play. This is a 4-minute video, so I'm not going to play the whole thing, but I just wanted to give you guys a sense of what this actually looks like in action, because it's really pretty cool. Again, no relationship to that company. It's just a nice video on YouTube that shows the different, the way that this would actually look intraoperatively. So this is going to be our burr hole. The dura is open there. They've inserted this port. Oh, well, bummer. Okay, give me a moment. Give me a moment. Let's see, how can we get that to play? For our IT folks, do you know how we can get this to play?
See if they can work their magic back there.
Get your computer going to extend screen, but you can drag it over onto the other. It's probably picking up two monitors.
Brief pause.
Thank you, Nathan.
All right, so your video is...
It's on Google Chrome. So it seems like only the...
Ryan, is there anything on your end?
Like, why is it not showing?
It's just doubling your screen.
No? Aha!
Except for, now you can only see it over here, so...
Oh, and we don't need to look at
Hold on.
Wayfair. Oh.
I went to the wrong one.
So we have a couple pop-up ads.
I completely...
Oh, no.
Hit the red X.
All right, let's try this again. All right, so let's watch on YouTube. And then... Okay, and you said it's
So
just
you
a...
can either drag it or you can mirror.
Thank you, Nathan.
You just need-
All right.
Thank you. Thank you both.
Okay. Very good. So,
You're hired.
this is a little trippy because I don't see it on my screen anymore. All right, so I will press play so that you guys can see this because it's cool. All right. All right, so this, as I mentioned, that's the port going in. So they have a burr hole, they're just kind of gently bringing the port down. That is the actual port, like once it's left behind, that clear tube, they have a retracting system that holds that port in place. And that's your visualization. And so I'm not sure, I believe this is a hematoma evacuation in this video, but yeah, so that's all the hematoma coming out. It kind of evacuates itself. It's under pressure. It wants to come out. And so they move forward with evacuating it. And let's see what else. They keep cleaning out the clot there, and this is it. That's the end. That's normal brain down there. I mean, it's a little damaged from the hematoma, but they've taken the port out, and everything's looking nice and clean. They're irrigating, and that's it. It's a pretty straightforward surgery. And ultimately, because it's minimally invasive and you're minding the anatomy, you're minding the functional anatomy of where these tracts are, it makes a big difference. All right, so now let's see about putting my PowerPoint back on for you guys. All right. Oh, but now they are seeing this screen instead of
I'm so sorry.
technical difficulties.
I'm so sorry.
It's okay. I'm not sure how to switch
Flip
that.
around.
Let's see. I don't have it on the top there.
There.
Uh,
Yeah. I can't see it though.
I can't see it.
Can you see it just from that angle? Oh, you can get
Yeah, here, help. Thank you.
Thanks, Jess.
Ah, voila. Technical difficulties. Always happens with videos. You always want to include them because they're great to visualize, but at the same time, it always messes things up. All right, so that summarizes the techniques that we use. And so I went through the MISTI technique, I went through the SCUBA technique, I went through the MIPS technique, and all of those are the different minimally invasive styles of evacuating hematomas. But the last point that I wanted to answer here is when. So should we operate? Seems like we should. How we operate? Seems like it matters. And timing. Now this is a little less definitive. So this was a study that was published in 2001. So this is where a lot of the caution around operating too early comes from, because they studied patients that were treated less than 4 hours versus those treated within 12 hours. And what they found was rebleeding was way higher in patients that went to the operating room in the ultra early setting, so in less than 4 hours. And so this is where a lot of the conversation started about maybe not taking them to surgery right away unless it's life-threatening at that point. And so then, more recently, these were published meta-analyses that looked at timing as well. And so this first one up top is a meta-analysis that looked at 6 randomized controlled trials, but before 2010, and showed there was a benefit for surgery in randomized patients less than 8 hours. But then they looked at the 8 to 24-hour window, they looked at the over to 24-hour window, but that did not really show much of a benefit. But specifically, there might be a benefit in those that were earlier. The one at the bottom here, the minimally invasive surgery, was actually a meta-analysis for MIS specifically, and what they looked at was less than 24 hours versus less than 72 hours, and they found lower odds ratio of death or disability in the patients that went sooner within that 24-hour window of time. And in this last one, this is an interesting meta-regression analysis that looked at studies. And what they did was that they had a pre-specified analysis of different factors they wanted to include as part of this meta-analysis. And they looked at age, GCS on presentation, ICH volume, and timing. And the only one of those that seemed to make a difference in functional outcome was actually, an improving functional outcome was early surgery. So this, still the timing is not completely decided on yet, but it does seem that at least within 24 hours makes a difference, but maybe not too early. You want to make sure things aren't actively bleeding still. All right, last couple of slides. I just want to highlight our program at University of Wisconsin and UW Health. Overall, 2024, we treated 700 strokes, 1,200 stroke code activations, and 21% of those come from outside of the Madison region, but 18% of those are hemorrhagic stroke. And you see our map here. There's Madison where our hub is, but we also have our hospital branch in Rockford, Illinois also. In conclusion, I hope I answered these questions well enough, but should we operate? I think the evidence supports it. And if so, how and when? Seems minimally invasive is the best approach, and timely, I leave that as kind of vague, timely, because I don't know exactly what time frame just yet, but it seems that earlier is better within limits. And that was it. So I have a QR code that will plug my contact information into your phone if you want to scan that, or you can do it the old style way and just type it in yourself. And then I do have a feedback form. Feel free to just post any if you have any. Always happy to hear about more things that you're interested in learning about, and happy to take any questions that you might have.
Dr. McGuire, Just a quick question on, so those were supratentorial analysis.
Oh,
Can
yes.
you just elaborate a little bit on the infratentorial, because we get very nervous. We don't have a neurosurgeon in our hospital. We do have access to one.
Sure.
But if you can elaborate a little bit on that and your experiences. Thank you.
Oh, sure. So, okay, so just to clarify, supratentorial is what this was mostly about. The whole talk was mostly about supratentorial. And the reason was because if you noticed in the guidelines, the separation, they're pretty clear studies that show benefit to doing surgery for infratentorial cerebellar hemorrhages. Where there's some question mark over the past decade or two has been what to do with above the tentorium, so the supratentorial bleeding. So for infratentorial or cerebellar bleeds, generally speaking, if they're about 30 cc's, so 3 centimeters or so in their diameter, that's usually around the time that we pull the trigger to operate. And so that usually involves a suboccipital craniectomy, and hematoma evacuation to decompress. It is not advised to only place an external ventricular drain in these patients because actually they can do what's called upward herniation. And so if you were to place an EVD on a patient that has mass effect at the base of their brain, then the swelling and the pressure can cause it to move upward, and that it can actually kill them. It's quite dangerous. And so in patients that have a large enough hematoma in the cerebellum, there's really good evidence to just go ahead and take them to the operating room and evacuate it immediately. And now, in that approach, that's not a minimally invasive approach. You actually just go ahead and open up the entire back of the skull, and you evacuate the hematoma, and that's that. So there's not really an MIS way to do that, at least not yet.
Quick question about selection, too. As we did some evaluation after the ENRICH trial, and then we started looking back at our ICH, we found that there are less patients using the ENRICH trial than what we used to do historically in terms of minimally invasive. And I was curious if you've run into that at all within your organization.
Yeah, we were actually just talking about this before I came up for the presentation. That it's interesting that despite having a lot of these studies over time, including the meta-analyses that have shown benefit to MIS approaches, as early as 2015, there were meta-analyses that showed benefit. The uptake for neurosurgeons to do surgery on supratentorial hematomas has been quite slow. Even with the ENRICH trial coming out, I've seen some hesitation to doing that. But I think that with more awareness about this approach and more awareness about the different approaches that are options to us, it'll become much more widespread. But where I trained versus where I currently work, there are very different practices and very different mindsets about it. And so, I mean, it's a good point. There's a lot of differences in how this has been approached over time, the different ways, the techniques and everything. And so hopefully with time, and now that the ENRICH has come out, there's going to be more patients that are selected for it. And at the end of the day, I think there is a case to be made that even if a patient is doing clinically well, if they have a hematoma and maybe some deficit, even if they're clinically well, there's benefit to taking the hematoma out because it changes the amount of edema around there, the secondary insults to the brain as well. And so there's some evidence that even if they're clinically well, that we should probably go ahead and take them. Just maybe not as an emergency per se. I don't know if that answered your question.
Yeah, it does a little bit. And you know, I think we're still learning and getting to know which patients are going to fully benefit from this.
Right.
You know, we in our organization, we used to do, 2015, we were doing all these minimally invasive hematoma evacuations, and we kind of swung to the opposite side, and now we're kind of swinging back and trying to find the perfect balance. So.
And I think it all goes down to the changes in techniques, because as I mentioned, like MISTI came out and it was a negative trial. And so, but that's a very different technique than this MIPS technique that has been described more recently. And I think this mindfulness to the functional anatomy is where it's key. So it's not just that it's MIS, it's that in the approach to it, you're doing as little damage to the structures around it as possible. And some places will try to do a functional MRI, for instance, with DTI, to look at the tracks themselves and really map out your plan if the patient's stable enough to do that before you take them to the operating room for that reason. But patient selection is definitely huge, but technique selection is huge too, I think.
Okay. And I have one other follow-up question,
Sure.
just about timing, because it is so loose. Do you use anything to kind of protocolize or try to guide, like when that 24 hours or 72 hours when it's appropriate, or can you address even how you're working through that? Because it's really hard when you say, well, not too early, not too late.
Right. Yeah, it wasn't a very satisfying answer, I think.
Yeah.
But okay, so my general practice for a patient that comes in with hemorrhage, the first thing to do is you have their CAT scan, you stabilize them, you know what's going on, but then I like to get that 6-hour stability scan, as long as they're stable, because it's very different if it's a life-threatening bleed and you have to go to the OR right then. That's a different scenario. That's not what we're really talking about. In patients that come in, they get a scan, you know they have a bleed, they're clinically stable, they're doing okay, maybe have some deficits, but they're doing all right in the ICU. 6-hour stability scan just to make sure that nothing has actively expanded, because that puts the whole situation a bit at risk, like that one study did describe, that rebleeding can definitely happen in these patients. And so once you have a sense of stability, the patient's still stable, usually in that 6-hour to 24-hour time frame is a good time frame to take them back for these spontaneous ICHs. It's a very different story for trauma as well. So that's my preference for this. And ultimately during that time frame, you're doing a lot of other things too. You're getting them monitored in the ICU, Keppra. You're doing all the things that they talk about in all the other sessions today. But that's how I like to look at it personally.
Sure. Thank you so much. I really appreciate it. Great presentation.
Oh, of course. Thank you.
I just wanted to, no question, I just wanted to add a comment from the AHA. We have recently launched a new quality improvement initiative specifically looking at minimally invasive surgery for ICH patients. So as we're hearing some of the comments in the room around different practice models and comfort level, this is something that the AHA has really taken a look to make sure that we're gathering sites in a learning collaborative to kind of process map where some of those identified gaps are, maybe decreased comfort level and improving the care of the ICH patient through minimally invasive surgical options. So you can always get more information about that from Sue or I. We also have an initiative website, but I just felt like the time was kind of right to let you know about that is something AHA is also focused on.
Awesome.
Thank you so much for the talk. That was so informative. And I think I have so many questions I could ask you. But I think what's interesting is that you said that surgeons aren't they're not adopting surgical intervention quite as quickly, I guess, based on some of the studies and the meta-analyses that are coming out. What are the best ways for, like a lot of the people here, we're non-surgeons, we're part of the stroke teams. What are the ways that non-surgery teams can partner with surgery to help adopt or implement minimally invasive techniques for ICH patients?
That is a good question. It's a very challenging question. So I will give some of my thoughts about it. I think part of the difficulty with the uptake for MIS approaches, and again, we were talking a little bit about this before I came up here to talk, is that you do have to have the right equipment for it, and you have to have someone that's trained in it. And so that's kind of a personnel issue as well as a system issue, because you need to have the resources available to actually do these approaches, people and equipment. And so I think that's the first thing. And then the second thing, because once you have that and you have someone really invested and interested in doing these types of surgeries, then it just kind of, the program can kind of build itself in a way. But a lot also goes to the system side of it and having someone really champion ICH at the hospital. And so having someone that is a representative at the hospital that's going to be, maybe it's a coordinator of care, maybe it's someone that's helping to create protocols for the management on the ICU side, the nursing side. So having that champion on site and then engaging in a conversation with the Department of Neurosurgery just to see if there is someone, a point person, who this is an interest of theirs for surgical approaches. So I think it's definitely collaborative. It's not just someone approaching neurosurgery approaching someone else. Like, it really involves a whole team to get a project like that and a program like that off the ground. But there are issues that can prevent it from coming to fruition, and a lot of it is systems-based. So if you have a champion at your site, if you're the champion, if you are the one that wants to get this going, I think a lot of it comes down to making sure those protocols are in place, or working with people that are interested as well in the ICU, and then talking and having that conversation with the department and see what neurosurgeon can also be your partner champion on it. Making sure that there's resources available. Because all of the equipment that I showed in there, the endoscope, the port that's used, whether it's brain path or what have you, they take capital investment from the hospital. And ultimately it pays for itself, but it requires approval and a whole process. So I think that, I don't know if that specifically answered it, because there's not, I think, a specific answer to the question, except that it requires a lot of effort, but as long as you're the champion on your side, you can start to engage key stakeholders from across the hospital. All right, great. Well, thank you so much for having me.
Thank you so much.
Feel free to reach out with any questions.
That was fantastic. Thank you.
And sorry again for the technical difficulties. I tried.
No, it turned out wonderful. Thank you.